Báo cáo ban tổ chức xin trân trọng giới thiệu bác sĩ Mamath Thomas trình bày báo cáo với chủ đề tái lập lại môi trường miệng. Sau khi hoàn thành bằng thạc sĩ của mình, bác sĩ Mamath Thomas đã trở thành một chuyên gia tư vấn hàng đầu về chỉnh nha, tập trung vào chỉnh nha phòng ngừa, cải thiện nụ cười và thẩm mỹ răng hàm mặt. Với đam mê của cô với phẫu thuật với nha khoa thẩm mỹ, tiếp tục hướng tới việc cung cấp các kỹ thuật nhanh chóng, dễ dàng nhưng ít xâm lấn, chủ yếu tập trung vào việc cải thiện nụ cười một cách ấn tượng và tức thì. Bác sĩ Thomas là quản lý sản phẩm TSG Dental và hiện có trụ sở tại Singapore. On behalf of organizing committee, I would like to introduce Dr. Mamath Thomas. The topic of presentation is Reboot the Oral Environment. Upon completing her master, Dr. Mamath Thomas has been a leading consultant orthodontist focused on preventive orthodontics, smile, makeover, and maxillofacial aesthetic. Her passion for aesthetic dentistry continued toward providing quick, easy, and invasive technique that focus on install smile. Dr. Thomas is a product manager for ZC Asia Dental and is also have the center in Singapore currently. Welcome, Dr. Mamath Thomas.
Thank you. Good evening, everyone. My name is Dr. Mamta, and I work as product manager for GC Asia, and I'm based out of Singapore. Thank you so much for giving me the opportunity to take part in today's scientific congress, and I'm going to be speaking about preventive dentistry. So let me just share my screen first. So today's topic, I'm going to be talking about rebooting the oral environment, which is nothing but taking care of the oral cavity or the oral environment as a whole and kind of resetting it by taking into account preventive measures and not just directly going into surgical or direct restorative options. So if we look at these guys here, which is the Streptococcus mutans, and which we all know are gram-positive coccus, which are responsible for the caries process happening in the mouth. Now, what do they like? They usually like lots of sugars, lots of carbs. They produce more acid, and this causes a lowering of the pH in the oral environment. There may be a chance of less saliva in a particular patient. So all these factors cause the gram-positive cocci or the strep mutants to thrive, and thus, as a result, we get weak teeth. We get teeth that are demineralized and are more prone to caries. So in reality, enamel and dentine, although we think decay, they actually dissolve, they get worn away because of the acids produced by these strep mutants. So caries can be defined as nothing but other than a dietary carbohydrate and saliva modified bacterial infectious disease. So caries, very simply put and to understand, is nothing but a dietary carbohydrate and saliva modified bacterial infectious disease. So if we look at the traditional philosophy, if we had a patient walking into our clinic, what we would do now is try to see what is wrong now. What did the patient walk in for? And somehow try to fix only that problem. We may not look at the oral environment as a whole. But by doing so, does the patient actually become healthier? Who is responsible for this caries process? It is as much the patient's awareness and education as well as we as dentists educating our patients. So we all know Dr. G.V. Black's philosophy. His philosophy in today's age we find quite traditional, because if you look at this cavity, he would go about talking about making an outline form, basically extending the cavity into areas where there is a higher chance or risk of caries, a resistance form, so that there is a prevent of fracture of the restoration or the tooth. So these are few of the forms we had to keep in mind while even doing a small or a simple cavity on a tooth. The outline form, resistance form, a retention form. So our cement actually stays. In this case, of course, it was amalgam. He was working at a time when amalgam was popular. And then convenience form for us to actually have a look and ease of placement of the material. But what we realized is over the years, in spite of following these forms, there was a failure occurring. Progressively below these amalgam fillings, the teeth would still continue to decay, and perhaps ultimately we would lose these teeth. So there's been a paradigm shift of sorts, if you can say, rather than the extension for prevention, which was what was followed in Dr. G.V. Black's philosophy. What we now tend to do or tend to believe is prevention of extension. We want to prevent unnecessary extension of this caries or of this lesion, so that there is a perfect sort of form. We want to be minimally invasive. So, having said that, we come to this concept called minimal invasion or minimal intervention, where we would like to cause as less damage to the tooth as possible. And how is this possible now? It's because we have a better understanding of the cariology process. We know which or how the bacteria actually act in the oral environment, what helps it thrive, what helps it decrease. And also, over time, we have a good development of dental materials. We have progress in the field of dental materials that actually help us minimize our invasive trends into the oral cavity. So minimal intervention essentially comprises of three strategies. First is to identify, to see which patient is at a higher caries risk and to identify active or precarious lesions. So first we need to identify, be it visually or through radiographs, we have to have an idea of what is going on in the mouth. Next, we try to prevent. And we try to prevent by possibly educating the patient on maybe the amount and frequency of carbohydrate intakes. Or also, we can try to prevent by protection of the tooth surfaces or using some form of preventive dental treatments. And this is what I will be elaborating on today. Then, of course, we cannot prevent, we would have to restore. But again, under restoration, do we do a minimal intervention sort of restoration, try to control the spread and do what is exactly necessary? Or we can think of a more surgical, like our usual drill, fill, and bill kind of approach. So, again, coming to Dr. G.V. Black, we are all familiar with this classification where he classified the teeth, the caries present on the teeth, depending on the site on which the caries was present. So, we have our class 1, which is on the occlusal surfaces of the posteriors and also in the uh, cingulum or the lingual surfaces of the anterior. Similarly, the class 2, which is on the proximal surfaces, the class 3 doesn't involve the incisal edge, the class 4, which is on the anteriors and does involve the incisal edge, a class 5 or a cervical lesion. And then, of course, we have the class 6, which is the pits and fissures. So, this is a traditional sort of classification which most of us have read or understood and practiced over the years. There is another classification which is not as popular and maybe not as well known, but it makes a little more sense in terms of giving us an idea of not just the site, not just where the caries has occurred, but also the size of that cavity. So the site can be either pit and fissure or a contact area or the cervical area. And each one is given a numbering of 1, 2, 3. And then depending on the size of cavity, suppose there is no cavitation at all, it is given a 0. A minimum would be 1, a moderate 2. So in a pit and fissure, a size of 1 would indicate a particular size of cavity. And of course, if it is extensive, it has a score of 4. So this is another sort of classification that we use when we want to describe where exactly the caries is occurring on a particular tooth. Now, there is another or a newer classification of sorts, and this is something probably what the patient would identify with. If we have a patient coming to the clinic and we explain to them a cavity in this way, probably this is something they would more be able to understand and get. So we can classify a cavity as small, as medium, as large. So when a patient walks in and we look or check their oral cavity and we say, oh, you have a small cavity. What is small? Small involves just enamel and minimum dentine. So this is easier to explain to a patient. Oh, you have a small cavity. It just involves the top layer of the tooth and a little bit of the second layer. You have a medium cavity. Perhaps there is more amount of enamel involved and dentine. And then, of course, there's large, where the patients themselves can see it is quite extensive and maybe there is a large cavity present on the surface. There's extensive enamel and dentine involved. So there's small, medium, large. Now, there can be something that is smaller than small. And that's what we call minimal intervention, or those are the kind of cavities where we would use a minimal intervention approach. So, what is smaller than small? You can think of minimal intervention, perhaps just prevention or restoration of the surfaces. Or you have something that is larger than large. And that, of course, would lead to the preparation of an indirect restoration or maybe an implant. So, there is this study done on minimal intervention dentistry where they say that it is now recognized that demineralized but non cavitated enamel and dentine can be healed. So, we can actually think of restoring or healing a tooth in spite of it being demineralized but no cavitation present. And that the surgical approach to the treatment of a caries lesion, along with extension for prevention, as proposed by GD Black, is no longer tenable, is no longer the norm. People don't want to just blindly follow GD Black's principle of extension for prevention, because if there is a chance to heal a tooth without using a rotary instrument, without using a burr, then that's the way forward for dentistry. So, coming back to our Streptococcus mutans, the people or the villains who are mainly responsible for the caries in our mouth, like I said, they like more sucrose, they love carbohydrates, and all this cause them to prove or produce more acid, and that will lower the pH. And all this is extremely suitable to make our teeth weak. Our teeth get especially weak. So, from this, we kind of understand that the decay process starts on the surface, right? On the surface of teeth. So, do you think it would be sufficient to just, if we protect our surface or if we do something to kind of strengthen the surface of teeth, do you think that would suffice to prevent or to stop the spread of caries? Yes, that is something we can think of. And are there such products which will help to kind of strengthen and solidify our teeth much more so that they become super strong and are more averse to or more resistant to decay? So, as we all know, the popular saying, an ounce of prevention is worth a pound of cure. If we can do something to prevent that decay before it actually progresses to a larger filling, yes, we should definitely think of such options or strategies. So, I'm going to be talking about restoration of tooth surfaces today. And under that, we're going to be talking about restoring tooth surfaces through remineralization, through fissure protection, and through root surface protection. So, like I said, the strep mutants are really thriving in the oral cavity because of all those factors: more carbs, more sugars, less saliva, and this causes the surface to weaken. So, let's look at options to restore the tooth surfaces. So, coming to the first aspect as to how we restore them through remin or remineralization. Now, we all know our teeth or the enamel is made up of hydroxyapatite crystals. They're crystalline and microscopically they will look like these rods. It's composed of calcium and phosphate and water molecules. Hydroxyapatite crystals is what our enamel is made of and gives it that tough crystalline structure. Now, if we see in the oral cavity, there is constantly demineralization and remineralization occurring. What is demineralization? In the presence of strep mutants and in the presence of low pH, there's more acid, so the pH is lowered. What happens? There's a leaching out of the calcium and phosphate ions. So this is what is called as demineralization, and this causes the teeth to get weak, and ultimately there could be a cavity that results on the tooth. Now, if only demineralization was happening and the other side there was nothing to put those ions back onto the tooth surface, we would all be left with weak teeth, broken teeth. We would constantly be at the dentist. We ourselves could be patients at some other dentist. Yeah. So on one side, there's demon happening, but the other side, there's something to balance it called as remineralization, where in the presence of higher pH, the calcium and phosphate ions in the presence of saliva gets put back, or the tooth kind of absorbs back these ions. How is this possible? It's possible because of saliva, and saliva is extremely rich in calcium and phosphate. And this again is made possible because of the presence of staturin. Now, staturin is a protein that allows calcium and phosphate to be available in a bioavailable form. The calcium and phosphate is bioavailable, and hence the tooth can absorb it back onto its surface, which allows the tooth to remineralize. So there is something that is artificially produced that behaves or mimics the staturin. What we have is a milk protein, and the trade name for it is recaldent. But what it actually is, this milk protein is called CPP-ACP, casein phosphopeptide amorphous calcium phosphate. Yes, that seems very complicated to pronounce, so let's just stick to CPP-ACP. Now, this CPP-ACP is a molecule, a milk protein that was developed by Professor Eric Reynolds in the University of Melbourne. And what this does is it exactly replicates the role of staturin. What staturin does in the oral cavity, this CPP-ACP can also do. It is an excellent delivery vehicle, and it co-localizes and makes the calcium and phosphate ions available. It allows the calcium and phosphate at the tooth surface to be in a slow release bioavailable amorphous form. So great, we have this molecule, but there must be some way it has to be delivered to the oral cavity, correct? So this CPP-ACP, what it does, it helps maintain a state of supersaturation of calcium and phosphate ions. It depresses the enamel demineralization. That means it helps to increase the remineralization, and it buffers the plaque pH. It increases or neutralizes the acid present in the mouth. So, how is it delivered? One mode of delivery is the tooth mousse. GC's tooth mousse or the tooth mousse plus. This is a paste form, and in this, it is a cream based paste form. And in this, we have this molecule called CPP-ACP. So, what is it actually? Like I said, it is a topical cream, like we have face creams and night creams. This you can call a cream or an anti-aging cream for the tooth, if you like. It's a topical cream with bioavailable calcium and phosphate. What it contains is essentially water and 10% of that CPP-ACP molecule. And then, of course, it has some food additives and some sweetener, coloring. So essentially, it is a milk protein, that CPP-ACP, which is delivered in the tooth mousse. And it is available as these 40-gram tubes. And there are a couple of flavors that are available, like the strawberry, melon, vanilla, mint. So that's the tooth mousse, which doesn't contain fluoride. Now we have a tooth mousse plus. A tooth mousse plus contains not just CPP-ACP plus fluoride. It contains CPP-ACP and fluoride. Now this fluoride, now CPP and fluoride together will give us fluorapatite crystals. That is what will be formed on the surface of the tooth. And fluorapatite is much more stronger and much more resistant to acid attack as compared to hydroxyapatite. So the tooth mousse is recommended for children less than 6 years of age because it does not contain fluoride. The tooth mousse plus is recommended for children above 6 years old and also for adults because it contains fluoride. So in this picture, you see if there is a non-cavitated lesion, okay, a tooth surface demineralized part, and this is the healthy part. An application of this tooth mousse every day, twice a day for about 3 to 4 weeks will actually show on the radiograph. You can actually see the remineralized part happening here. This is the tooth surface. You have a demineralized part, but with the application of this tooth mousse or tooth mousse plus over time, that non-cavitated lesion actually remineralizes. So it can be applied also in the office, in the dental office with a tray. And you can see here for a period of 5 months, it was applied and observed, and there was a remin happening of the white spot lesions here. In this area, if you notice, it helps in the treatment of white spot lesions caused by demineralization. And again, study done on molar incisor hypomineralization. So the use of that remineralizing agent containing CPP-ACP, like the tooth mousse, because the tooth mousse is a vehicle which carries this molecule, resulted in a significant improvement in dental sensitivity in patients with MIH. So what are the indications? To rehydrate and rebuild enamel subsurface, to raise the pH of acidic saliva. Like I said, it buffers the acid and raises the pH, making the teeth stronger and less resistant to attack by acids. Post-orthodontic treatment, it is very useful, especially when we see there is residual where the brackets have been attached, there could be chances of demineralization. So after ortho treatment, if we regularly recommend the use of this tooth mousse, you can see good results. And bleaching, it reduces the sensitivity caused post bleaching. And generally, in teeth sensitivity, the tooth mousse is extremely useful to use. And of course, the key point, it is a preventive strategy. So, like I said, to reboot the oral environment, we look at the oral cavity as a whole. And this is one such product that can act as a preventive measure or a preventive strategy in high risk patients. How do we use it? Very simple. You can squeeze a small amount of the tooth mousse onto your fingertip, just a pea-sized bit, and then you can apply to all the teeth with your fingers. And then with your tongue, you can just spread it around your all the teeth so that it covers all the teeth. You leave it in the mouth for 3 minutes and then you expectorate, after which you're advised not to rinse your mouth or eat or drink anything for about 40 minutes to an hour. Like I said, we can also use this tooth mousse in the dental office if a patient comes in and they want us to treat them. So what we do is remove excess saliva and then we apply the tooth mousse on the tooth surface. Sometimes you can use a tray as well. Load the tray and apply it on the surface. And generally ask them to localize it or use their tongue, and then encourage them to hold it for 3 minutes. Like I said, you can spit out, but try not to eat or drink anything for 1 hour following treatment. The taste is quite pleasant. In fact, the vanilla could even taste sometimes like flavored yogurt or ice cream. So there is no unpleasant taste in the mouth, and it is possible to not eat or drink anything for at least 40 minutes to an hour after using this tooth mousse. So, like I was saying, post ortho treatment, usually there'll be a lot of residues on the tooth which are not actually visible to the naked eye. So, these resin residues you see will be visible on etching the enamel. So, you apply the enamel, you remove the etchant, and then you can see these resin residues. And after the removal of these residues with microabrasion, what you do is advise the patient to use this tooth mousse or tooth mousse plus continuously for about 4 to 8 weeks. And you can see a change in texture or even a change in the appearance or the brightness of that particular tooth because of the remineralization that's happening because of this CPP ACP molecule. It vastly improves the surface of enamel, and you can actually see there is even the vertical grooves on the labial surface. There'll be like a subtle reduction in that after, of course, a cycle of microabrasion. So the tooth mousse contains CPP ACP, and the tooth mousse was a mode or a vehicle of delivery. Now, what is another mode of delivery of this CPP ACP? We have what is called as the MI varnish. The tooth mousse was in a cream or a paste form. The MI varnish is like a paint, or as the name suggests, a varnish. It's available as a unit dose, and we can just, with a micro brush, paint it on the tooth surface. Now, usually the popular in-office fluoride products, if you see, they all are, a lot of them are 5% sodium fluoride varnish, of course, but then you have some which are in this form, the APF or the acidulated phosphate fluoride gels and foams, and then some of them are about only 2% sodium fluoride gels. So there are a lot of popular in-office fluoride products, and some of them may even require like the use of trays to apply them onto the teeth surface for maximum effect. Now, coming to the effectiveness of a fluoride varnish. Why is it effective? So by actually using a fluoride varnish or by painting it on the tooth surface, studies have actually shown that it reduces decay by 43% in permanent teeth and about 37% in primary teeth. So this definitely shows that there is an extremely good effect by just painting this MI varnish with this molecule of CPP-ACP onto the tooth surface. How does it actually work? So calcium is found in plaque, okay? In the oral cavity, there is an abundance of calcium found. It can be in the plaque, it can be in the biofilm, or it can be in decay that is starting in enamel porosities and generally in inaccessible areas of the mouth. And if there is an active caries lesion, the chances of calcium being higher in these regions are more predictable, are more present. So imagine we apply sodium fluoride varnish on the surface of the tooth. What happens is the calcium that is present in the oral cavity, either in the plaque, the biofilm, they combine with the fluoride, the sodium fluoride, the fluoride of the varnish, and they form a calcium fluoride reservoir. They turn into a globule like this and they act as a reservoir. And this preventive effect of this reservoir will last as long as the varnish stays on the tooth surface. So, for example, imagine we apply that MI varnish or that topical sodium fluoride varnish onto the tooth surface. The pH is about 7 then. The fluoride will combine with the calcium and we have these calcium fluoride globules which is sitting on the surface of the teeth, on the enamel surface. Now imagine there is a keriogenic challenge. The pH suddenly drops. There is a tooth that is being attacked by caries. So the pH will fall. And that's when these globules of the calcium fluoride reservoir will kind of burst. They open and release the fluoride ions into this caried lesion. So these fluoride ions will combine with the hydroxyl ions here and will neutralize the acid attack. What we're left with is zones of enamel remineralization because this fluoride has combined with the hydroxyl ions and we get fluorapatite crystals. And like I said, fluorapatite is much more acid resistant, is much more resistant to caries attack. So they kind of neutralize the areas in which active caries lesions occurs and start forming areas of remineralization. And all these areas have fluorapatite crystals, not hydroxyapatite, but much more resistant fluorapatite crystals. So this is how fluoride varnish essentially works when we paint it on the surface of the enamel or the tooth. So GC's MI varnish consists not just of sodium fluoride, it has 5% sodium fluoride, but what makes it even more powerful is this 2% of CPP ACP that is added. Like I already explained the effects of CPP ACP, we have like a unit dose, a powerful dose of MI varnish being applied on the teeth. So the fluoride itself is great for the calcium present in the oral cavity, but adding to it is CPP ACP, which makes it super strong and makes the saliva and oral environment super saturated with all these great ions of calcium fluoride and CPP ACP. So this unique CPP-ACP technology is contained in GC's MI varnish. It is easy to paint on teeth. You just take a micro brush and you can just paint it on like how we apply nail varnish even. And the taste is great. There's nothing unpleasant about it. And it doesn't leave any sort of yellow tinge, which sometimes is seen in the Durafat. So all these factors make the MI varnish an excellent choice as a preventive strategy, especially in high risk caries patients. So again, applying it is very easy. The tooth surfaces, like I said, it's available in a unit dose like this. About 0.5 ml of the varnish is present. And this one unit dose is sufficient to cover both the upper and lower arches. The tooth surfaces need to be just cleaned and slightly and dried. We don't need to do prophylaxis as such. Then we use a micro brush and then apply a thin uniform layer on all the teeth. And in spite of there being water or saliva, there's no need to worry. The MI varnish will still set. And once applied, it should remain undisturbed on the teeth for at least 4 hours. So after this application, we instruct the patients to avoid during that 4 hour period to avoid eating anything sticky, hard, or drinking anything, or toothbrushing, flossing. Ideally, they should not be having anything for the next 3.5 to 4 hours for the maximum effect to occur and for this varnish to kind of harden. So here again is a study done with the control and with the MI varnish. You can see it is on the X-ray or on the radiograph. You can see over time samples treated with the white varnish and TCP or enamel pro varnish. You can see the subsurface. There is still demineralization. It appears as a dark layer. But with the MI varnish, samples treated with this MI varnish shows excellent efficacy to resist acid because you can see the subsurface also has a good remineralization showing even on the radiograph. It is not radiolucent. There is a clear area of remineralization that has occurred because of the MI varnish. Also, as compared to many other of the varnishes present in the market, at different points in time, if you see, the MI varnish has excess or the cumulative fluoride ion release is the highest with the MI varnish, and even the cumulative calcium ion release is the highest in the MI varnish. Coming to the next, it's about fissure protection. So, in restoring of tooth surfaces, we need to also consider protecting fissures, especially of the erupting molars, because they are at a very high risk. And why are they at a high risk? Because they have a long period of eruption, about 12 to 18 months. And the operculum here is an excellent source of plaque retention. It is a sensitive tissue and very uncomfortable to clean. So many times we just tend to skip it and don't clean it. And newly erupted enamel is less acid resistant as compared to a completely erupted tooth. So as you can see from the graph here, the newly erupted molars have a very long time of eruption. Hence, they are more prone to acid attack and decay. So in the past, the prevention strategies were more focused on fully erupted teeth with a resin fissure sealant, not a GIC, not a material containing GIC, but a resin fissure sealant. And these resin sealants required acid etching. Like any composite resin, it required acid etching for micromechanical reduction, for retention, followed by the application of that low viscosity resin. And prevention of caries is dependent on the duration of sealant retention. And there has to be a 100% seal for that resin sealant to actually have effect and not cause decay under it. So these fissure sealants, when correctly placed, they've proven to be effective, but the results have not been always great. So resin fissure sealants, as we see, 92% of the teeth actually started developing caries under this sealant, and 73% had caries extending into the dentine even. So it showed a failure of sorts with the resin fissure sealants. Now, why did this happen? The reason is because we need to look at the structure of the enamel present in the fissures. In newly erupted teeth, the fissures are actually like this, very dense and aprismatic. They're about 30 microns thick and they're found on all primary teeth. They're extremely dense and they're called as aprismatic enamel. What is present here on not the fissures, the adjacent tooth surface is prismatic enamel. What is present in most erupted or fully mature teeth. So this is a cross-sectional view of a sound fissure, and this is kind of Mother Nature's way of protecting the tooth or the newly erupted tooth, you can say. So this, like I said, is aprismatic enamel, which is present in the fissures of newly erupted
Ở cái
teeth.
răng mà đang mọc á, thì cái mật độ men nó rất là đặc, và khi chúng ta sử dụng cái soi mòn á, nó sẽ gây ra cái hình mẫu mà lưu giữ nó rất là kém, không như là cái dạng men mà có lăng trụ, mà nó sẽ khi etching nó sẽ tạo ra cái hình mẫu lưu trữ tốt hơn. Do đó mà với cái hình thể lưu trữ kém này như thế này, khi mà chúng ta bôi resin nó sẽ không tồn tại được lâu. Đó là lý do mà cái xi lanh hố rãnh của GIC á, thì nó vẫn còn ở 93% mà chám bít với lại cái xi măng chám bít lỗ rãnh GC này, và không có cái xi lanh hố rãnh GC nào nó làm cho phát triển sâu răng. Thì nếu mà đối với nó còn một mức thấp đó, thì nó vẫn còn bảo vệ cái mô răng rất là tốt. Thì với cái GAC đây là cái bề mặt răng có cái ion canxi, thì nó kết hợp với cái ion carboxyl từ cái GAC, và đây cái liên kết này nó rất là mạnh, là liên kết dán rất là mạnh, nó là giao diện dán của GAC và với men, và nó có thể xảy ra giữa cái lớp men và lớp GAC, và nó tạo ra cái lớp mà kháng sâu răng rất là mạnh ở cái răng mà mới mọc. Cái sản phẩm mà chúng ta có thể dùng là gì? Chúng ta có những cái con nhộng mà Fuji 7, và nó chứa là gấp 7 lần cái sự phóng thích fluor cho hơn các loại Clasionomer bình thường, chứa nhiều strontium hơn, và nó chịu được môi trường ẩm. Nó có ở hình dạng, nó có màu trắng và màu hồng, và chúng ta có cái con nhộng là Fuji 7 EP, là nó có cái công nghệ là CPP-ACP. Nó làm cho cái Fuji 7 này nó rất là mạnh trong việc là hoạt động như một chất mà bảo vệ hố rãnh. Thì chúng ta có thể màu trắng và là màu hồng, nó có cùng cấu trúc cấu tạo. Đây là cái nếu chúng ta bôi thường thì nó sẽ đông trong thời gian bình thường. Nếu mà các anh chị muốn nó đông nhanh hơn á, thì sau khi bôi á, thì chúng ta sẽ chiếu đèn trong vòng 30 đến 40 giây thì nó sẽ đông ngay lập tức. Đối với cái màu hồng của Fuji 7 á, thì nó sẽ đông bình thường, và nó giúp chúng ta đánh dấu được cái vùng mà hố rãnh mà chúng ta đã bít ở trên miệng, ở trên răng. Đây là một cái hình ảnh của cái răng mà bị thiểu sản, răng cối lớn. Thì sau đó là chúng ta bôi cái Fuji 7 sau 12 năm tái khám á, các anh chị sẽ thấy là có cái sự dày lên và sự tái khoáng hóa rất là mạnh, rất là đáng kể trong trường hợp này. cái chủ đề cuối cùng tôi nghĩ là tôi đã quá giờ rồi, là chúng ta nói về cái bảo vệ của cái chân răng, bề mặt chân răng. Thì các anh chị biết là cái tục nướu á, nó sẽ thường là nó nhiều hơn 3 ly. Được báo cáo là ở gần 50% của cái dân số mà trên 60 tuổi, khi mà nó bị bộc lộ cái bề mặt chân răng á, thì nó sẽ dễ bị hòa tan hơn 6 lần so với cái lớp men. Và do đó là chúng ta cần cái phương tiện để chúng ta bảo vệ cái bề mặt chân răng này tốt hơn. Các anh chị có thể dùng cái con nhộng Fuji 7 này để bôi lên bề mặt chân răng ở màu trắng, dùng màu trắng hoặc màu hồng. Tôi trở về cái phần cuối của cái bài hôm nay. Thì chúng ta liên quan đến cái phục hồi bề mặt răng và bề mặt của dưới men. Chúng ta phải tái lập lại cái môi trường miệng. Như tôi đã nói, thì cái con vi khuẩn Streptococcus mutans là con vi khuẩn chính. Thì nó có thể làm phân rã được cái bề mặt men. Nó là một cái tình trạng bệnh do cái sự thay đổi chế độ ăn và thay đổi cái nước bọt ở môi trường miệng do vi khuẩn. Chúng ta phải kiểm soát và phòng ngừa bằng sử dụng những cái sản phẩm phù hợp trong môi trường miệng. Cảm ơn.
Thank you very much for your wonderful presentation, and we look forward for your new studies. And on behalf of School Dentistry, we would like to send you the certificate and congratulations and all the best to you. Thank you very much.
Thank you. Thank you so much for giving me a chance to be a part of this and extremely well organized. Thank you so much.
Thank you.
Yeah.